All right. Well, hey everyone. So I thought I'd try out a new format for this JG Extra. This one is going to be. I thought I'd make it a little bit more entertaining if you had some narration over it. I know I don't have as nice a soothing voice as, say, Morgan Freeman, but I thought it'd be a little bit better than just reading the notes or the PowerPoint. So whenever I can, I'll try to use this format if you guys like it. So this JG Extra deals with which post-congenital heart surgery baby should I oxygenate? As some of you know, I got to rotate through the pediatric ICU the last few weeks, and pretty interesting. We had a one patient who came in SVT. She also happened to have congenital heart surgery, and basically it took a little bit. It was a little bit difficult in the ED to break her SVT. She came up to the ICU and made for some interesting teaching rounds. So, without further ado, let's get to the talk. So there's essentially three surgeries that I wanted to talk about, and you'll see why these are important. The first one, or first, most of the procedures that I'll be talking about have to do with hypoplastic left heart syndrome. Now, some of you may already be saying, Jonathan, this isn't going to be that common a thing that we're going to see in the ED. Excuse my cat for meowing in the background, but not going to be a common thing we see in the ED, but that's essentially why I kind of wanted to do this. It's just something that we don't see every day, like cholecystitis. So it's just something you want to keep in the back of your head. So if you can't remember the specifics, at least just remember that there are a few important points you want to try to look up when one of these babies comes in. So without further ado, the first procedure that we'll talk about is the Norwood procedure. This is going to be the first of 3 open heart surgeries that these patients will get in the early part of their life. The Norwood is going to be done within the first few weeks of life. Okay, the goal here is to start rebuilding the heart to essentially make it a better pump to get blood, to the lungs and to the body. And what you can see is, as you can see here, this is hypoplastic left heart syndrome. So almost no ventricle, almost no aorta. So if you see here, normally they have the pulmonary artery going from the right ventricle to the pulmonary arteries. Here, they ligate that pulmonary artery, and what they do is they create a neo-aorta. So you get part of the pulmonary artery is now essentially diverted to the rest of the aorta, and now you're getting blood from the right ventricle going to the body, okay, going to the lower extremities, going to the brachiocephalic, the left column carotid, and the left subclavian. What they do, or how does blood get to the lungs? I guess would be the next question. What they do is they build the BT shunt. Actually, there's 2 things they can do. One is the BT shunt, one is the Sano option. The BT shunt is going to be connecting the brachiocephalic to the pulmonary arteries, as you can see here. So now some of that blood is going to be coming here, up here, and through that BT shunt, and then it's going to go into the lungs to get oxygenated. Okay, not the most efficient way to get blood to the lungs, but better than what they had before. So that's the first surgery, and keep in mind why this is important in a little bit. The second procedure that they're going to have done is the Glenn shunt. Okay, so this one is done around 4 to 12 months of age. Okay, so Norwood, first few weeks of life. Glenn shunt, 4 to 12 months of age. Here, the goal is to essentially reduce the workload of the right ventricle. You can see, obviously, the biggest change is right here. Your SVC is ligated, so that now your SVC is no longer going to go to your right atrium. Any blood coming from the upper body is going to go through your SVC, and that's what's going to give blood to the lungs. So that now, when blood comes from the lower body and comes into the right ventricle is only going to have to pump blood out through that neo-aorta. Okay. Also an important point, which you'll see in a little while, of why you want to remember that the Glenn shunt has the SVC only connecting to the pulmonary arteries. So the next surgery that they'll have done is the fenestrated Fontan, or the Fontan for short. This one is the goal here, or is to separate oxygenated from deoxygenated blood. Okay, this one is done 12 to 24 months of age. So Norwood, first few weeks. Glenn, around 4 to 12 months. Fontan, 12 to 24 months. Sometimes they'll often do a heart cath done before the surgery to make sure it's safe to go ahead. And what they're doing here is also bringing blood from the IVC now. It's going to go to the lungs, in addition to the blood from the upper body going to the lungs. Excuse me. What they do is they install this, basically blocking off blood from the IVC to the right atrium. Okay. Oh, and I forgot to say earlier in the Norwood, if the patient does not have an ASD already, they create an ASD, or an atrial septectomy it's called, so that blood coming from this side into the left atrium can go actually into the right atrium, so that all oxygenated blood essentially is coming into the right ventricle. But anyways, fenestrated Fontan, IVC is now connected to your pulmonary arteries. Okay. So, and this was an example of the Sano modification. This one is for the modified Norwood, where instead of having a BT shunt connecting the brachiocephalic, now blood is going to be coming directly from the right ventricle through the Sano into your lungs. Okay? So, why is this important when the child comes into the emergency department? Okay? When patients with a Norwood come in, they will have obviously less oxygen content in their blood. When you put the pulse ox on them, your staff is going to come running in to get you because they're probably going to be somewhere in the 70s or 80s. And if they're really doing bad, obviously they'll be much lower. But 70s to 80s is actually where they normally live. And this is the instance that you do not want to just pour oxygen into them to try to get quote-unquote nice oxygen saturation of 100%. The reason being, if you remember from physiology, what's oxygen going to do in your lungs? If you give oxygen to any part of your lungs, they like oxygen, so the pulmonary vasculature is going to open up. Okay? Now, when blood comes into this neo-aorta from the right ventricle, into that brachiocephalic and through the BT shunt, if you open up your lungs, now blood is going to get preferentially shunted or stolen essentially into the lungs. So now you're going to have less blood coming up to through your carotid, less blood going out to the body, less blood going everywhere. Essentially, most of it is going to get shunted through your BT shunt into your lungs. Okay. The reason this is bad, obviously, less blood up towards your brain is going to give you a hypoxic encephalopathy. Less blood everywhere through your body is going to cause ischemia. That's going to cause acidosis from poor perfusion. So it's essentially this kid in front of your eyes is give them oxygen, give them a nice saturation, and then they just start deteriorating in front of your face. Okay, so this is the instance when you want to remember that Norwood equals no oxygen greater than 85%. Okay? N for Norwood, N for no oxygen. All right? The other interesting point that this patient made us learn about was if a kid comes in and you want to give them any kind of blood that's going to be affecting their heart, in this instance it was adenosine, the important point with adenosine is, remember, it has a very short half-life. So if you have your little baby here, we'll do a very crappy drawing, you have your legs, your arms, you get a peripheral IV right here in the arm or even in this side, you push adenosine, blood comes back into the SVC. It's not going to go to the AV node where you want. It's going to go into the lungs, circulate around, and finally it's going to come through pulmonary veins into the right atrium, right ventricle, and it's finally going to get to attack that AV node. But by the time that happens, you're basically not going to have any more adenosine left because, like I said, it has a very short half-life, like you guys already know. It's all going to be metabolized by that time. So if you have a patient who has a Glenn shunt, you want to establish a lower extremity peripheral IV. That way, the blood will come through the IVC instead and go directly where you want it to go. Okay? So, that's pretty much it. Just a few quick points I wanted to make, interesting points that this patient taught us about. So remember, if they have a Norwood, okay, N for no oxygen greater than about 85%. The actual number will kind of vary who you talk to. Just remember, saturations in the 80s is the goal for these patients with a Norwood. Okay. Let's see. The other point was if they have, well, this kind of goes with the last one. If they have a Glen, just remember G for give oxygen. Okay, oxygen's okay in this standpoint. And if they have a Glen, remember, their upper body is no longer connected to their heart. It's going to be going directly to your pulmonary arteries, the venous return, essentially. And so if they have a Glen, and you want to give a cardioselective drug, mainly we're talking here about adenosine because it has such a short half-life, you want a lower extremity peripheral IV. Okay? So that does it for this JG Extra. Hopefully you guys learned a little bit of something, and let me know if this works out, and I'll talk to you next time. Thank you.